All right.
Thank you.
Thank you.
Bye.
Bye-bye. Okay. We are going to jump into our next session with Dr. Mickeal Key. I have a brief introduction that I would love to do before she shares the information that she will be sharing today. Dr. Key is a consultant with Global Alzheimer's Platform Foundation, where she assists with implementing and the latest recruitment science practices, especially as it relates to the inclusion of historically excluded racial and ethnic groups from clinical research. She leads cultural competency training program within the organization and is currently leveraging BioHarmony's data to provide insights into both recruitment efforts and AD pathology within underrepresented populations. Dr. Key is a cognitive neuroscientist and a visiting assistant professor of neuroscience at Butler University in Indianapolis, Indiana. Currently, her research is focused on how lifestyle interventions affect brain structure and cognitive performance in older adults. She also examines clinical trial methods through a health equity perspective to make lifestyle clinical trials more inclusive. I would love to introduce you all to Dr. Mickeal Key.
Hello, hello. Let's see. Let's do, okay. Which are you seeing a presenter mode or are you seeing the official?
Presenter mode.
Here we go. How about that?
Good.
Okay, perfect. Okay, fantastic. Thank you so much, Dr. McGee Rogers, for that beautiful introduction. And I'm so happy to be with you all today. This first session really did the heavy lifting. So there are many of the topics, especially as it relates to how our different kind of identities inform Alzheimer's, not only a diagnosis, and progress, but other kind of aspects of the clinical enterprise as well. So I'll just go ahead and hop into the slides and yeah, I'm excited to share this information with you. So my kind of duty is to talk about Alzheimer's disease, women's health, and intersectionality. And I just want to kind of set the stage for what I mean by intersectionality. It was originally a term, and it's a social theory coined by Kimberly Crenshaw, kind of originally to talk about the intersectionality of identities in the legal system, but since, right, has seen like broad application to multiple different disciplines. So I'm applying it here because it's very fitting, right? So if you consider intersectionality as a social theory, that can broadly refer to a framework for understanding how various aspects of individual identity, including race, gender, social class, and sexuality, can interact to create unique experiences. Like I said, the original, kind of definition was in relation to oppression and privilege, but I think it's applicable here that I insert a risk and resilience, right? So you can have this very kind of intricate interaction between biological sex, gender, race, ethnicity, caregiving status, social determinants of health, and social and cultural factors. Now, I know that there is, a lot of research and, people in these kind of distinct areas that do work, amazing work, right? But what I think is not happening to the extent that needs to is that we're talking to each other, and we're really kind of considering how all of these different factors work together to inform Alzheimer's disease and risk. So I want you to kind of keep this figure in mind as we kind of talk through maybe a couple of these different factors and then how those like overlapping individuals who fit in overlapping identities. So multiple of these factors kind of affect them, how that increases their risk for dementia and their participation or not in clinical trials, which is kind of what we're all here for. Just to give us kind of a base, so I'm starting off with the relationship between Alzheimer's disease and women's health. Just in case these aren't familiar to you, let's talk about that relationship. So we know, at least in the US, that there are at least 12 million women who are either living with Alzheimer's or caring for someone with Alzheimer's. So almost two-thirds of Americans living with Alzheimer's are women, right? And so we know that age is one of the most significant kind of risk factors for developing Alzheimer's. And so women in their 60s are twice as likely to develop Alzheimer's disease in their lifespans, more so than even cancer. So we're talking about a lot of people kind of being affected by this particular disease disproportionately, right? To take that a step further, we also know that more than 60% of Alzheimer's and dementia caregivers are women, right? So one over a third of dementia caregivers are daughters. So again, we're seeing this kind of disproportionate weight of a caregiving status for women. We know that depending on cultural and social kind of aspects, women take on more caregiving tasks than their male counterparts. And if you kind of even think a little bit further, and it was mentioned in our previous session that and about 19% of women Alzheimer's caregivers had to quit work because of their like kind of caregiving duties. So already you're seeing this overlapping with economical financial stability and women and Alzheimer's risk, right? So you're already seeing this overlapping network. And then just in terms of caregivers and that weight that can be presented with that duty, right? The need for counseling and respite care then is very much needed kind of in this population. So then this naturally kind of segues into let's talk about caregiving though. Again, in the previous session, there was some really beautiful kind of firsthand accounts of what that caregiving kind of experience can be like. But just so that we're kind of all on the same page, we know that there are psychological kind of effects of caregiving that can be in the form of stress, right? So the stress related to caring and making, for the well-being of another individual. We also know that caregivers are at a higher risk of developing a depression. Specifically, if you kind of take a look, I have the Lancet 2024 kind of figure that talks about, the different risk factors for dementia and how they relate across the lifespan. And if we think about this large number of women who are taking on these caregiving responsibilities, we already know that depression, stress, and things like that are high risk indicators in midlife. So if you consider, the addition, right, of caregiving, responsibilities, then you're seeing this double up. You're seeing this compounding kind of effect of caregiver status. It was mentioned previously about the financial kind of implications of taking on caregiving duties and responsibilities. These can be anywhere from just out-of-pocket expenses for healthcare, missing work, or having to switch, jobs or positions so that it's more flexible to accommodate those caregiving responsibilities. We've talked about again, the kind of social network, whether the existence or lack thereof and how that can affect the caregiving experience. And then again, I won't belabor the point that has been, talked about already, considering unique challenges when you layer gender and LGBTQIA community. There's some unique challenges that exist with caregiving that kind of already been talked about, as well as those cultural factors. Speaking of those cultural factors, there are kind of depending on your kind of cultural perspective, and I'm using this Hofstede's cultural dimensions as just like an illustration of how differences across cultures, how variations and differences across cultures. And so this comes into play because one, there can be cross-cultural views on aging. We've already heard about that, already, right? There is, kind of differences in, respect for elders versus ageism, right? This is related more so to the power, kind of distance, which is just about the degree to which a community expects power to be distributed. We know that sometimes in a family there's one person, a matriarch, or there's one person that kind of makes the decisions, and there are other kind of communities or cultures where that decision making is distributed among the members. And so when you think about giving care, when you think about participating in a research trial, those are really important contexts to consider for recruitment and retention kind of efforts. There are, again, differences in family structures and caregiving expectations. So, like, who is responsible for the caregiving, and of course, there's this influence of cultural values on specific health behaviors. So, while we understand there are systemic, institutional structural levels that impact our health, we know that at least the cultural level there can be kind of differences in values around health behaviors that are associated with risk for developing Alzheimer's. So hopefully what you're taking away from here is just that there are many kind of social and cultural factors that can layer on with these other kind of identity characteristics that can influence a person's risk and their kind of participation in getting and help and care. Okay, speaking of those kind of structural aspects that affect our health, we call those social determinants of health, right? And so you know, of course we, a lot of us here, right, already know, these stats on disparities across racial and ethnic groups. And so again, I won't belabor this too much, but I hope what you can catch from this slide is that there are still a lot of knowledge gaps that persist, right? So we know that, African Americans can be twice as likely to develop Alzheimer's disease. We know individuals, Hispanic and Latinx are 1.5 times likely to develop AD. But there are other, populations that we don't really have enough information on because they are not included in research, right? So we know that American Indian and the Alaskan Native individuals have a risk that may be similar, that's pretty high and maybe similar to African Americans, but there's still a knowledge gap that persists there in ensuring that their representation in clinical trials matches their the population in general, right? For Asian Americans, again, not a monolith, but in general, Asian Americans are considered to have the lowest kind of risk of the social and ethnic kind of groups, but still, there are many areas of knowledge where gaps persist for this community as well. And then with Native Hawaiian and Pacific Islanders, again, there's a knowledge gap, that persists about the exact kind of disparities in this group. There was recently a paper that kind of looked at a genetic aspect of dementia risk, looking at APOE, and found that in this particular population, there was like a 25% prevalence rate of the APOE4 allele, which is associated with a higher risk factor, right, or a higher risk of developing, AD. But what that means and how to put that in context is still something that is very active, like 2025, very active, research area that we're still not sure because of their underrepresented, existence in these clinical trials. All right, so the biological mechanisms, right? So this is something that I think kind of needs to be talked about more as well. So if you consider sex difference in the development of AD, we can see that these are also factors that should be considered in clinical trials and research at a much higher rate than they are kind of currently. So at least four of those mechanisms. One are the sex differences in microglia number and the response to phagocytosis. All right, so this is just the idea that we know that Alzheimer's and related dementias are inflammatory kind of based diseases. And so if there is a difference kind of in immune response to that inflammation, then that could lead to a higher risk of females having a higher incident rate of Alzheimer's than males. We also know that there are sex differences in metabolism during aging, and particularly we can talk about the role of metabolism. So we know that estrogen is a protector of mitochondrial health and function in females and provides, some protection, right, against cellular stress and dysfunction. But if you think about the lifespan, the life and the reproductive kind of course of females when they enter menopause, right? Then there is the removal of that estrogen, right? Estrogen levels, drop significantly, therefore then exposing a vulnerability to, cellular dysfunction, mitochondrial dysfunction. And there are thoughts that, and research kind of looking into the role that hormone replacement could play in maybe alleviating this issue. Okay. Then we have sex differences in basal autophagy. So, and its connection with tau and amyloid accumulation. So, again, the idea is that you have females that are having this reduced reactivity to, clearing these, plaques and tangles that accumulate and cause, neuronal damage. And so again, peeping, giving us maybe a peek into why females might have a higher risk for developing Alzheimer's disease. And then we have sex differences in the gut microbiome. So this is another kind of very active area of research where we know that differences in the biodiversity of the gut microbiome for men or women can contribute, and its connection to neuroinflammation, metabolism, and autophagy can also be kind of like a fourth link to how individuals might incur or have a higher risk for developing Alzheimer's disease. We can also look at clinical presentation and diagnosis. So we know that women tend to perform better on these verbal memory tasks, which can actually mask early symptoms and delay diagnosis. This also means that there's a decrease in the likelihood of early intervention for women as well. So this has implications across, kind of screening tools that we use in ADRD research, as well as, how we interpret blood-based and digital biomarkers. Okay, so I'm wrapping up to my kind of takeaways, which I think can be across, multiple different types of research trials, but I did kind of break them down into specific considerations for pharma trials and non-pharma trials. So for pharma trials, okay, given what we've, kind of talked about, we understand that underrepresentation across racial ethnic groups and the LGBTQIA community is still an issue, and those efforts are still very much needed. That we should consider participants' need need for support when allocating funding, both during recruitment and during the study. So really paying attention to recruitment and retention, because we often, focus on the recruitment part and not the retention part. That we should consider sex-specific pharmacokinetics given the differences in biological mechanisms, and that we consider study design when we think about these kind of intersectional overlapping identities, right? So stratifying by sex, considering menopausal status and hormone therapy, and also looking at monitoring sex-specific adverse events and efficacy. And then the final takeaway, two, with non-pharma trials, considering that there may be differential effects that may exist based on these intersectional subgroups. And so considering that factor, um, thinking and considering more often flexible research designs. So possibly needing, like if you're thinking about hormone replacement and a behavioral intervention, considering those biological kind of differences. Again, caregiver dynamics. So both on the potential participants maybe serving as a caregiver, and could affect their participation, but also knowing that caregiving can present an additional stressor that can impact study outcomes. And then again, with study design, tailoring recruitment and retention strategies so that they're culturally responsive, using culturally responsive approaches, and then of course, accounting for sex and gender identity characteristics in your adherence and engagement metrics. So that's all I have. I believe I am at my time, so I'll post my contact information. And yes.